Well, hello, and welcome to my case study on pediatric genitourinary. So, a 5-month-old female is brought to the clinic for a fever of 102 for 3 days, has been irritable, and has a decreased appetite. So before you start reading any further, start thinking about if this were an NCLEX question, what would you think is going on with the baby? Would you think that they have some type of infection because they have a fever? That's good. That's a good way of thinking. Would you start thinking, well, what are 5-month-olds most likely to get? What kind of symptoms or signs of irritability and decreased appetite could that mean? Are you thinking maybe a upper respiratory tract infection? So when you are going through case studies, it's helpful for you to kind of think of what would you be thinking if this were an exam question. So now we can keep reading. So the RN does an assessment. And what does the RN find? No upper respiratory tract infection symptoms, either by history or by looking at the baby. And really no other symptoms. The mother or father that brings the child in denies everything. There's nothing else that they've noticed. They haven't noticed a stuffy, runny nose. They haven't noticed the baby pulling on their ears, anything else. No rash. So just a fever, irritability, and decreased appetite. On physical exam, the baby weighs 14.6 pounds, and you know to divide that by 2.2 to get your kilograms. So the baby weighs 6.6 kilograms. The heart rate is 150. The baby's crying, has a respiratory rate of 30. The baby does have a temperature of 102 rectally. The baby's just acting fussy the whole time in the office. But the exam is otherwise unremarkable. Again, there's no rash, no sore throat, no irritation in the throat, etc. So there's high suspicion for a urinary tract infection. So the provider orders and the RN completes a urinalysis. And it is found that there are positive blood, positive nitrites, and white blood cells in the urinalysis. They send a urine culture off to the lab, and that, of course, is a culture. So you need to wait for those bacteria to grow. And 2 days later, the results come back that the urine culture does show greater than 100,000 E. coli per milliliter. So this baby does have a urinary tract infection. Now, at the time that the baby's in the clinic, you don't wait for the culture results to come back before you treat. You have the urinalysis results. You will automatically go ahead and treat the baby for a urinary tract infection. You will wait for the culture results to confirm that it is positive. And because the urine was retrieved by a sterile catheter, they were able to do the urinalysis through a sterile specimen. So that's helpful. You could also do a urinalysis through a sample from a U-bag, where you put a little sticky bag on the outside of the baby's urinary tract so they will pee into the bag. Sorry about that. But then you're risking contamination. So if you can get a sterile catheterized sample, that is the best. And if you know you're going to send out a urine culture, then this is the best as well. So urinary tract infections. Remember that the urinary tract is normally sterile. So if there is any bacteria on the inside of that bladder, you know that there is an infection there. The organism that most likely causes a urinary tract infection is E. coli, mainly because of the location, because it is found in the anal region. When you are thinking about urinary tract infections of infants, toddlers, and children, their signs and symptoms might be different than what you would find in an adult patient. We know that adult females, it's a very common infection, a urinary tract infection, that sometimes the provider doesn't even order a urinary culture, that it is just you do a dipstick or even by symptoms alone, and an antibiotic is ordered for 3 days. But this is your huge pens up point. Urinary tract infections in babies and children is a big deal, especially in babies. Sometimes it goes undiagnosed, where the baby will come in with symptoms of fever, irritability, the baby's crying, the provider will look in the ears and the tympanic membrane might be red because the baby's crying, and it may be falsely diagnosed with a ear infection with an otitis media. Given antibiotics, kills the bacteria in the urine, but maybe nobody ever knew that it was a urinary tract infection. This could be very, very dangerous. So huge pens up. You do not want to miss a urinary tract infection in a baby or a young child. So the signs and symptoms that you're looking for might be different from that of an adult. So what are you going to look for? Fever. If it's a child, they may complain of nausea. Obviously, a baby can complain of nausea, but you might notice the baby vomiting. Chills, abdomen or back pain. They usually don't complain of burning urination, especially if they're too young to have verbal skills. So you don't have that to go on. But sometimes the older child will just complain of a tummy ache, and that's the only symptom they get. So you want to check that urine. Lethargy, they just might just be feeling crummy. Poor feeding, not acting right. That older child, especially if they are potty trained, might have urinary frequency or feeling the urge to go more frequently. The older child may have burning with urination. There may be foul smelling urine in the infant, toddler, or child. And a potty trained child might be incontinent, and they might have blood in the urine. So how are we going to manage this baby that has a urinary tract infection? Well, first we have to get rid of the infection. It's that E. coli infection that is now inside the sterile urinary tract. So we need to eradicate that. So we need to give an antibiotic. This is a bacterial infection. So one antibiotic that is used, and we are going to use for this baby, is ceftriaxone, and the safe dose is 75 milligrams per kilogram every 24 hours. We're going to give that intramuscularly. So 75 milligrams times the baby's weight is 6.6 kilograms. So you will get 500 milligrams. So we'll give that as a one-time dose. Then we're going to have the baby return the next day. We're going to check the temperature, see if the baby's improving, see if the baby's eating, drinking, if the baby's dehydrated. If the baby is dehydrated, they may have to be hospitalized for IV antibiotics. If the baby's doing better, they may at that point then switch to an oral antibiotic. Next, promoting comfort. Because the baby is having a fever and uncomfortable, we can administer acetaminophen or Tylenol. We will give acetaminophen to reduce that fever, and the dose range for acetaminophen is 10 to 15 milligrams per kilogram per dose. So that's a pens up. Kind of remember that one. It's a standard given all the time, so you want to remember it. And the concentration for the Tylenol liquid medication is 160 milligrams for every 5 milliliters. You want to get comfortable on doing these calculations, these types of calculations. So 10 milligrams times 6.6 milligrams will give you 2 milliliters after you do the calculation. And 15 milligrams times 6.6 kilograms will give you 3 milliliters. So you will instruct the parent to give between 2 to 3 milliliters, or you can give them an exact dose every 4 to 6 hours as needed. Now we need to think about preventing recurrence for urinary tract infections. So we're going to move me out of the way here. We're going to have the baby return to the clinic and repeat that culture after completing the course of the antibiotic to ensure that the bacteria is indeed gone. So further diagnostic testing that we need to be thinking about if it's an infant that has a urinary tract infection. Again, this is pens up, this is serious. Many times further diagnostic testing will need to be ordered because there could be some reason of why the baby is getting this urinary tract infection. Remember, it's not like an adult female that can get multiple urinary tract infections, sometimes there's a reason why the baby is getting a urinary tract infection. So we need to look at a renal ultrasound many times to see if there is an obstruction, such as a hydronephrosis shown in this picture, or we will be doing a VCUG or we will doing a VCUG, which is a voiding cystourethrogram. And that's where they put a catheter in the urinary tract and put a dye in there and take pictures and see how the urine is flowing. Because remember, normally the urine gets formed in the kidneys, comes down the ureters to the bladder and out the urethra. But sometimes babies have what we call reflux or vesicoureteral reflux, VUR. And that's the backflow of urine. So sometimes there's this reflux. You're probably familiar with gastroesophageal reflux, where that's the stomach contents coming back up through the GI tract. But um, urinary reflux is the urine refluxing back up towards the kidneys, and that can cause contamination and scarring, and it can cause long range damage for the kidneys. I did have a baby in our clinic once. Actually, it wasn't a baby, it was a child that had seen a previous provider. It did not happen in our office, but they saw a previous provider, and it had exactly happened what I had said earlier, where as a younger child or baby, this child had had urinary tract infections, but it was not diagnosed. And this child had urinary reflux. So the whole time, this urine is causing this backflow and scarring. And the child actually ended up having to have a kidney transplant. So we can't miss a urinary tract infection on a baby. It's very dangerous. And so we need to do further testing to find out if there's a reason behind it. That's it. Thanks.